Well, thanks for being here. I appreciate it. I am Deanna Critchley. I am the Area Vice President for Pharmacy at Cigna Healthcare. So, whoops. My thing came off. I guess I'll just hold it. So I manage a pharmacy team with clinical pharmacists as well as account executives that manage all of our existing business for anything under 3,000 in the New York, New Jersey market. And then we also participate and help with all new business. So I'd be happy to talk to anybody after I present as well. So today we're going to talk a bit about GLP-1s, get some facts out there. There's a lot of misinformation out there about it, as well as how that impacts cardiodiabesity, how that impacts your medical claims, as well as whether or not as an employer you want to consider covering it. So usually this is an interactive presentation. I want to get all this information out. So afterwards, I'm going to be lingering around. So if you have questions, I'm happy to answer any of them that you have. So as far as weight management, right? We all know that we're in a overweight issue within our country right now. 72% of Americans are considered overweight and 42% are considered obese. So there's been a lot of conversations as far as how that impacts medical plans and how your health plan should be covering and helping your customers as well as their dependents. Cardiodiabesity is a term that refers to all of how being overweight impacts you as an individual as well as your costs, right? So think of cardiovascular, think of diabetes and how that contributes to being overweight and what that actually could contribute to, whether that be cancer, musculoskeletal, right? So there's a lot of things that being overweight can impact you as an individual. So GLP-1s, as I like to say, entered the chat, right? So that they have been out for quite some time, and we'll get into that in a minute. But GLP-1s, I am sure, actually, let me take a step back. How many of you have heard of Ozempic? How many of you heard about it through social media? Okay. So we'll get through some of the facts about what these are and what they mean and exactly what they're doing to your body. So GLP-1s stand for glucagon-like peptides. So they're a hormone in the brain that actually controls your appetite, controls your impulse to eat. It regulates your insulin production and your blood sugar levels, and they are extremely effective in doing so. And they have a very nice side benefit of helping you lose weight, which is kind of where our conversation we'll talk about today. So the drugs on the left-hand side, which Ozempic is the one that, like as everybody mentioned in the room, they had heard of, is probably the most popular. These drugs are glucagon-like peptides, GLP-1 agonists, that are actually approved by the FDA to treat type 2 diabetes, right? Diabetes is what you're help controlling your insulin production and your blood sugar levels, and they are extremely effective. So some of the ones that you probably have heard about, as I mentioned, are Ozempic, Trulicity's been out for some time, Victoza, Mounjaro. They all have different chemical makeups, but basically all do the same thing. These drugs are not approved by the FDA for weight loss. So if you do not have diabetes, by the FDA guidelines, you should not be taking these medications. That's probably one of the big misconceptions that's out there right now, and you can thank our celebrity friends for doing that and posting their social media. And Ozempic is usually the catalyst for that. That is for type 2 diabetes. The drugs on the right are actually FDA approved for weight loss. Wegovy is probably one of the more popular ones that have been out. It's the same chemical makeup as Ozempic with semaglutide, but that medication has different escalations, different dosage amounts, different strength, and is specifically targeting weight loss, controlling that impulse gene. How they work is they actually, like I said, mimic that hormone in your brain, making you not hungry. So you're not hungry, you're not thinking about food. It's almost taking it out of the equation, right? So right now I'm thinking about, what am I having for lunch today? Am I gonna go out with my friends? Should I have a drink, right? These are the things that you're thinking about. When you have these GLP-1s, you're not thinking about it. You're not eating. That's how effective they are. And they haven't just come out. They've been out since 2005. Byetta was the first one that came out. It's been out for quite a while. And you can see the timeline as they have come out. And at the end of the timeline, they're not going away. There's 10 more that are right now looking at FDA approval and coming out. Most of these, if not all but one right now, are injections. They're weekly injections typically, not oral medications. Now some are seeking oral medication approval as well, so you can imagine those that have not maybe taken them because they're for fear of injections, maybe taking them now because they're going to be made in oral form. So the GLP-1s have been out and have been very effective, as I mentioned. In 2022, Wegovy came out, and that was the one that kind of made the splash about the weight loss. So Cigna actually was a little bit forward-thinking, I thought, and a thought leader in saying, okay, we know this is coming out. We know these GLP-1s recently are getting a lot of headlines in the press about weight loss. We're going to tighten up our utilization management on our GLP-1s that are not approved for weight loss. So our utilization management program actually says, as a diabetic patient, did you try metformin first? And do you have diabetes, right? There's a couple things in there that we want to make sure that the right person is taking the right drug. And for our clients that don't intend to cover weight loss, we want to make sure that those drugs on the left-hand side of that slide are actually being used for type 2 diabetes and not weight loss. So we tightened up our utilization management program in anticipation when Wegovy came out and you were getting phone calls into your office to say, are we covering this? And we said no. The next thing they're going to do is go try to get Ozempic and Mounjaro for weight loss, right? But our utilization management was kind of controlled in place to make sure if that wasn't your intent as an employer, that that wouldn't be covered. So this is the big question, right? And this is where my team and I spent a lot of time this year with our clients at our utilization management meetings, and it would derail our meeting in talking about our year-over-year trend in utilization is, what do we do, Cigna? Do we cover weight loss medications? I have people in my office asking if we cover them. I have new hires coming in and asking about salary and PTO, and then the next question is, do you cover weight loss medication? Because the other employer that's offering me a job does. That's a lot of pressure for you guys as an organization to make that conversation. So we don't necessarily, at this point, and I'm speaking from Deanna's perspective, have an opinion to say, yes, you should cover it or no, you can't. I think it's very employer specific, and I think time needs to tell, and you have to actually really consider your benefit philosophy, how you cover it, what type of population you have. Do you use it as talent acquisition? Are your competitors offering that? Do you offer lifestyle management programs and that's part of your well-being philosophy? Do you have long-term employees, right? Because if you have a turnover, do you want to cover it, they lose all the weight and potentially go benefit another employer with their lower weight loss? So these are all things to consider when covering weight loss medications. And the only thing I will caution if you're thinking about it is once you make the decision to cover it, that's a really, really hard benefit to pull back from, right? So if you decide to cover it and in 2 years your trend is very high and your pharmacy claims are really high and it's becoming unsustainable for your organization to fund it, it's really tough to say, sorry, employees, we're pulling this benefit back. That's not going to make anybody's job in this room fun. So the other question is, but if I cover it and I'm spending $1,200 a month on my employee or their dependent, right? Maybe off, like, think about like $12,000 to $15,000 a year for you to take Wegovy. Will my medical expenditures be lower? Right? Am I going to have less musculoskeletal? Am I going to have less cancer? Am I going to have less stroke and emergency room visits for heart attacks? And the answer is right now we don't know. Even though they've been out since 2005, really the high amount of people taking them has been in the last maybe 3 or 4 years. And we're not really seeing a lot of positive data right now on lower medical ROI expenditures versus what you're paying out of pocket for the drugs. And right now, these drugs are forever drugs. They're forever drugs. So you take it, you lose the weight, you're maintaining your insulin and blood sugar levels, and if you go off of it, you will gain the weight back. So that's really what we're seeing. So the study up on the screen was done by the BBC, and the red line is actually showing the person or the control group that was actually taking a semaglutide medication, and you can see the incredible amount of weight loss in a short period of time. And the minute they stopped, the weight creeped back on. So now we're trying to dig into why are they stopping? Why are they not taking it anymore, right? We know why they gain the weight back, right? Because when they stop taking it, that impulse gene turns back on, right? That impulse gene now is, I have a couple friends actually, or I should say one in particular, who is type 2 diabetic, takes Ozempic, takes it on Sundays, the injection. And by Friday night, he is ravenous. All of a sudden, he gets very hungry, he wants to eat, and he's waiting for his injection to take on Sunday. Because all of a sudden, now he's thinking about food again, right? It's that impulse gene is off, and you're getting hungry. The other thing it does, which I failed to mention, is it also slows your digestion process down. So it's making you feel full longer. So the way that it's actually producing insulin in your body is also slowing down your intestines and your stomach and how it's digesting food, so you're full longer. So another reason when you stop taking it, you start eating. When you're also not hungry, you're not eating protein, and you're not eating vegetables, and you're not eating fruit. So what happens when you do that? You lose muscle mass, right? So now you hear Ozempic face, right? And like people are losing muscle mass is they're not eating, and they're not eating the right foods. It's one thing to not, eat your cakes and cookies and your Oreos, or you're drinking your wine. But for that, you're not even eating your good stuff. So I think when we look at this, is why are they not taking it, right? So we looked at the study. Cigna did our own internal study, which we haven't yet done a white paper about. But we looked at people taking a semaglutide over an 18-month period, and 66% of them were stopping within a 6-month period. That's a lot of people to stop taking the drug for it to be so effective. And some of the reasons that we're looking at and that we're seeing is that you see how quickly they lose the weight, right? So maybe I've dropped 50, 60 pounds. I'm fitting into those jeans from high school. I'm looking really good. I'm feeling really good. And I'm exercising a little bit, and I'm not eating, so I don't need to take it anymore. So they stop taking it, not realizing how impactful and how effective it is. So I think that could be a big thing. Some people are taking it and they haven't made lifestyle changes, right? The other big thing with these is they don't have the best side effects. So think of gastric in nature side effects: diarrhea, stomach pain, vomiting, sometimes like really absolute pain and stomach paralysis are like the worst ones I've heard about. Doesn't really make you feel really good. And let's remember too, like eating and drinking and going out is a very, very social part of our society, right? You meet friends for dinner, you meet friends for drinks. If you're not eating, you're not hungry, people miss that. They want to enjoy, they want to be part of it, right? So they think, okay, maybe I've lost my weight, I don't need to take it, and then they stop. So I feel like that's kind of where we're still looking at the longevity of this to see, is it really worth you as an employer covering these drugs if they're not even going to continue taking it? So a few things, as I mentioned, about what we have been doing as an organization. Actually, you know what? I forgot one other thing. Another thing from an organization perspective is we did a study as far as if employers were covering these and what employees were thinking about it. And we actually did a study, or 9am did a study rather, and looked at employees that were considering leaving jobs. And they said 40% of employees surveyed would actually consider taking a GLP-1. And 20% would actually leave their current job to go to another one that covered it. So that's pretty significant for hiring managers, right? To think about, like, is that really going to impact a possible hire? So again, you guys are under a lot of pressure. So as far as how Cigna's been managing it, as I mentioned, utilization management is key. So if you're not covering weight loss medications today, I would strongly recommend that you ask your carrier if you have utilization management in place today. So are your GLP-1s, your Ozempics, your Mounjaros, your Trulicity, is that being guardrailed for you? Because if you're seeing an incredible increase in costs for these GLP-1s, it may not be managed properly. And you could have people using them for off-label use. There's been shortages, there's been cost issues, people getting access, people that are type 2 diabetes that can't get their medications because they're being used off-label. So another reason to consider having that guardrail in place. So as I mentioned, Cigna has had that in place, so we're always checking before somebody is getting Ozempic or a like type of GLP-1, do they have type 2 diabetes? And did they try metformin first? So metformin has been around forever. It is in generic form. It is a heck of a lot cheaper than Ozempic. I think you can get it for like a $10 or $20 supply. It's extremely effective in actually treating type 2 diabetes. Doesn't have the amount of side effects. You still lose a little bit of weight on it, maybe not as excessive as Ozempic and the like. But it is very effective and has been the gold standard in the American Journal of Medicine for doctors to prescribe as a first-line defense for type 2 diabetes. And many people can regulate it just fine. The tide where we're seeing shift is sometimes metformin doesn't work, and these GLP-1s are so effective in covering it. Sometimes doctors now are going right to prescribing them. So to have those guardrails in place is very important. So that's my little public service announcement I would recommend for you. As I mentioned, Cigna automatically does that. We talk to our clients about that, and we recommend that that's in place today. We also have our medical and pharmacy typically sold together in our integrated plan. And when our clients are integrated, and there's lots of benefits about that, and I can talk to you about that if you want, is we actually can claim check. So we have an internal system called RX Claim Connect. So if I discover I'm type 2 diabetic and I go fill my medication, instead of it being stopped at the prior authorization for my Ozempic or Mounjaro, the system will automatically see that I had an AC1 level check on my medical file. It may see that I've tried metformin before, and that claim automatically goes through. We don't contact the doctor, we don't stop the point of sale for the member, and typically about 40% of our claims will automatically prior auth because we have that medical data on file. And that goes for other types of prescriptions as well, but specifically here for the GLP-1s. So that's something to consider. So again, utilization management. Our clients, we don't automatically cover weight loss medications. So the other GLP-1s we talked about today are automatically covered because they're for type 2 diabetes. The medications for weight loss are what we call an add-on or a buy-up. So that's something we'll decide with the client if they want to cover it at installation or during renewals. So that obviously will impact your claims costs. And if the client does choose to cover it, we recommend that they have utilization management in place for those particular drugs. So again, Wegovy is not for somebody who is 25 pounds overweight and has their 30-year high school reunion and wants to take that so they look good for that reunion. This is for people that are obese, that have medical conditions and have tried other means and it's not working for them, and that they would be a candidate with the right BMI. So right now the BMI for weight loss medications at Cigna is a 30 for a 30 BMI with 2 comorbidities, so think PCOS, asthma, diabetes, or a 32 BMI. So in order to get that covered, that's what we recommend, and that's what we have in place today. Our new solution, which we've been going out and talking to our clients about, is called Encircle RX for Cigna, and it is being made available to our self-funded clients on 1/1/25 for those that decide to cover weight loss drugs either today or they'll be covering it in the future. This program will have a fee in place, but will also have a cost cap or a guarantee, depending on what the client wants. And this is a little bit more of a tighter control. So we actually, the BMI before was 27 and 30. So the BMI for this one, we actually are increasing it, so my bad. So if you just cover weight loss medications, it's 27 with 2 comorbidities or a 30. This one, we actually increase the BMI to make it a little bit harder to get for people that actually are on the cusp of being overweight. So this now is a 30 BMI with 2 comorbidities or a 32 BMI. This program works much more in tandem and parallel with the customer to make sure that they understand the side effects of the drug, what they're taking, that it's an injection, are they the right weight, and most importantly, now we enroll them in lifestyle management programs. So if they pass the BMI test, they fill the drug, we'll require them to weigh in through our OMADA program. We require them to weigh in again in a couple more months. There's going to be nutritional counseling, exercise programs, things that they need to do in addition to taking this medication, right? We all love instant gratification, losing that weight quickly, but we want them to be able to maintain it so your costs also will continue to hopefully go down. Well, thank you very much. As I mentioned, I'll be here if you guys have any questions. I'm sure you probably have some, so I will be here. So thank you, I appreciate it.